In order to better unify our national criteria to treat the Hodgkin lymphoma in Venezuela, back in 2016, we decided to update and publish our new national guidelines. And outside clinical trials and in the real world data, we have to outline three major differences between our national guidelines and the international ones. First, in terms of early disease, we have to say that recently there is a tendency to reduce the treatment according to the results of PET-CT. In Venezuela, we don't have the opportunity of PET-CT, but only between the 20 and 25% of our patient population. So we decided we won't have any PET-driven treatment modalities because we can afford the PET. The second aspect is patients with advanced disease. In advanced disease, we previously, in 2011, published our data related to the standard treatment for Hodgkin and in frontline setting, ABVD. And unfortunately, our results were inferior to the results reported internationally. So we got a higher rate of progression or resistant disease with ABVD. In that time, we thought that that was because of two main reasons. The first one was our patients are really advanced stage patients. They have an IPS score between 3 to 7. Also, there are some aspects related to nutrition or social status. The second one, and more important, is that 52% of our patients requires consolidation treatment with radiotherapy. And we found a delay time between the end of ABVD treatment and the possibility to initiate radiotherapy. So maybe this is the reason why we have such a poor results. With that in mind, we changed our advanced treatment strategy for BCOT escalated, and because it has a better progression-free survival, it has demonstrated a better overall survival, but also, and more importantly, it does have less progression or resistant disease. So for us, it's extremely important, this aspect, because with a 30 million population in Venezuela, we only have 2 transplant centers. And one of them just 4 beds, and the other one 2 beds. So for us, it's extremely important to get in patients not only in remission, but to stay cured, because we have less chance to rescue him or rescue them with transplant. And the third and last aspect is related to refractory relapse disease. Again, international data show that salvage chemotherapy really produces a low number of complete remission. And today, it has been demonstrated that the complete remission is the best prognostic factor to go to transplant. So with the new agents, the combination with salvage chemotherapy and novel agents as brentuximab vedotin, we can duplicate the complete remission rate before transplant. So we decided we have to combine them, brentuximab and the salvage chemo, always before transplant, and then after transplant, The ATHERA trial demonstrated that there has been an advantage in terms of event-free survival with 16 cycles, but because of a matter of cost and availability, we have to cut down the number of cycles to only 7, because the pivotal studies with brentuximab vedotin showed that we need almost between 6 to 7 cycles to obtain the best response. So these are the differences when we live in a third world country.